So with no further ado, I'd like to move to introduce you to our next speaker, Professor Mike Roberts. I'm sure many of you know Mike, or certainly know of him. He's clinical lead for the National COPD audit since 2000, and he also led the European program between 2010 and 11. He's also program director at UCL Partners Academic Health Science Network for the Integrated Comorbidities Program, and is a general and respiratory physician at Barts. Mike.
Okay, thank you very much indeed. So my remit is to talk about building quality improvement into an audit from the start. And if you're expecting all the answers, you'll be sadly disappointed because they're coming in the next talk. But quite a lot of what I have to say, I think, does resonate with what I heard from Dominique's talk. And I'm sorry I missed yours, Kevin, but I'm sure it was just as good. So COPD, for those who are not in the know, chronic obstructive pulmonary disease is a disease that tends to affect older people, but can affect young people too, usually caused by cigarette smoking, but there are exceptions to that. There are certain forms of industrial exposure, and in the developing world, exposure to biomass fuels, which can also produce this. It's a narrowing down of the air passages, sometimes linked in with damage to the alveoli, causing emphysema as well, and the symptoms the patient gets tend to be progressive breathlessness, sometimes accompanied by cough, sputum production, and it is a pretty disabling and debilitating illness in its more severe forms. There is no cure for it at all, and what we do on the whole is try to improve patients' quality of life and symptoms, and of course encourage people as strongly as possible to discontinue smoking at an early stage. So that's the condition, and it's important to audit because somewhere between 2 and 3 million people in the UK have COPD. We don't know how many. We think there's a massive amount of underdiagnosis in primary care, and you'll see later also in secondary care of COPD. So we're really just putting a finger in the wind a little bit as to the exact size of the problem, and that is a big problem for us. Altogether, the health and social care costs are around about £1 billion a year to the UK economy, and it's one of the commonest reasons for unscheduled emergency admission for medical reasons to NHS hospitals. So it's a big deal, and as Sally reminded us earlier, 90% of the care is going on in the community and primary care and not in hospitals, but a high proportion of the spend goes on in the hospital system. An overview of the programme is that we have been commissioned and funded by HQIP, and many thanks to you for that, for a 3-year plus 2-year programme. And my understanding of that is that if we deliver the goods after 3 years, we may well get another 2 years, and if we don't deliver the goods, we're in trouble. So hopefully we will deliver the goods, and I think we are on track to do that. The audit programme is led by the Royal College of Physicians, and my boss there, if you think I'm looking a bit haggard and tired, it's because my boss there is Kevin, and he drives us really, really hard. And we're working very closely, though, with a number of other organisations, the British Thoracic Society, the British Lung Foundation, Primary Care Respiratory Society, and the Royal College of GPs. And I have the team mainly sitting over here today who are supporting that programme, who do all the work. I just get the credit. We have 3+1 key work streams, as you can see from here, and I apologise if you're sitting at the back, you probably can't see anything at all, so I'll just briefly take you through them. So there are 3 key work streams. One is a primary care audit, there's a secondary care snapshot audit, there's a pulmonary rehabilitation snapshot audit. Pulmonary rehabilitation is one of the key elements of evidence-based intervention that's non-pharmacologically derived, which patients particularly are keen to see and we feel is very good value for money. And then we've been commissioned to do a 1-year feasibility study of incorporating a patient-reported experience measure into the audit programme, and that part has now been completed. The primary care audit will be pretty much passive as far as the general practitioners are concerned, so data will be taken out of clinical systems automatically. The secondary care audit will run every 2 years. The first one is just completed this year, and that will involve a prospective case ascertainment with retrospective case note audit. Whether that's electronic or paper will depend upon the individual secondary care trusts. It will be a combination of clinical audit of consecutively admitted cases, but also an overarching view of the organisation of care and the resources that go into care in those organisations at the time of the clinical data collection. And the pulmonary rehab audit is very similar. It'll be looking at service quality and patient outcomes over a 3-month period. It commences in January next year. So we're having a cycle of audits which will not all coincide with each other, but will allow the team to be able to manage those, and of course clinicians to be able to manage their workload as well. We are collecting patient identifiable data. So that means that we'll be able to link the various elements of the audit to provide a complete care pathway for the patient. So we'll be able to look at things right across the care pathway. And that, as you heard from Emma, has brought us huge difficulties with getting permissions to collect that kind of level of detail of data. We think we're almost there through a very convoluted route, and we're going to have to sort of bend over backwards and double to do the right thing. But we feel that that's appropriate. We've been through those various committee stages to get to where we are today, but it has delayed the audit by about a year. Some of the measures that we're collecting, there's a variety of things, clinical processes and some outcomes. We're being able to link our data to other sources such as ONS and HES. So we're going to be looking at mortality, length of stay and readmission rates, and a variety of other things. The databases are relatively large, and one of the lessons, I think, for all of us is that we need to be more precise and concise with what we collect. But sometimes we have to go large in order to understand what's really important, so we can then focus down on the narrower issues. Having said that, this is not the first COPD audit that there has been. We have quite a bit of experience now. With the first audit in 1997, 36 hospitals in the UK. We looked at various process and outcome measures, culminating in much larger scale audits in 2003, 4 and 2008, when we had nearly 100% of trusts across the United Kingdom at that time. I just want to stress this audit, because it's HQIP funded, is in England and Wales and excludes Northern Ireland and Scotland for information governance reasons and for funding reasons. But these previous audits were UK-wide, and we extended the 2008 audit to include process outcomes, resources, organisation of care, patient experience, and some data that was collected from primary care as well. And then in 2010, as you heard, we did a European audit in 13 countries of COPD care in hospitals. And if anybody wants to ask about that, I'd be very willing to talk about the difficulties. If you think collecting data in the UK is difficult, try collecting data across 13 European countries. It has many challenges, but also a very rewarding experience. So we have a lot of experience of audit, and I think basically the main learning from that, as we heard from Dominique earlier and from others in the audience, is that we've kind of concentrated too much on the right-hand side of the cycle and not enough on the left-hand side of the cycle. So we've done an awful lot of data collection. We're really, really good at data collection. Trusts collect data for us. Clinicians are engaged in collecting data. What we're not so good at is making the changes and implementing those changes that we should be doing on the basis of the data that we're collecting. So this time round, we felt we needed to recognize that right at the beginning and try to introduce a quality improvement process within the audit as best we could. And it's not for want of trying, I guess, that we've got to where we have got to, which is not that much change. And again, sorry, the yellow is probably totally unrecognizable there. This is some of the data that we feed back to units and produce in national reports. So this is looking at whether people across the audit program were given assisted ventilation if they came into hospital with severe acidosis. Assisted ventilation is probably one of only 2 interventions you can make in hospital which will potentially save a patient's life. So it's absolutely critical to focus in on this. And in this slide, you can see that in a high proportion of units, nobody was given that type of intervention at all. And when we mapped that to the organisational work, we found that it was because they just didn't provide that kind of service. So if you come in that perilous state to that hospital, you die. So that was quite an interesting finding right at the beginning. So feeding back that kind of information is quite useful. And then for the European data, this is looking at treatment for patients. This was some data we produced for the Belgians. So Belgium is here, benchmarked against the European average, and then all the other countries across there. So we make it pretty, we put colours in, we try and benchmark and make it interesting to engage clinicians. And then we went on road shows with the DH in the 2008 data, and we tried to put people into quartiles in terms of their performance. So here we have organisational scores for various services. This is assisted ventilation, rehabilitation, supported discharge, oxygen therapy, and the different acute sites along here. And red means you fall into the bottom quartile nationally, green you're in the top quartile nationally, and amber means you're somewhere in the middle. And you can see that if the data were perhaps released to patients and you happen to live halfway between these two sites, you might decide where you wanted to go for your treatment if you could do. Often, of course, patients in this situation don't have a choice about where they go, they just end up. But sort of naming and shaming by giving this kind of data feedback in regional meetings we thought might have an impact. And then you can't see this again from the back, I apologise, I didn't appreciate the size of the screen when I put these slides together. But here we are actually naming, these are all the hospitals in Wales. It actually names every hospital there in Wales. It provides the data for every hospital in Wales. So you can see whether services are provided or not in those hospitals. It's pretty explicit. And again, what we haven't done is put these data out yet into the public domain. But even when we present them across clinical groups, there is usually a gasp of surprise when people see these kind of variations in the data. So providing data which is benchmarked, which is colourful, which provides information about specific sites can be helpful. And then at each individual site, we produce reports and have produced reports which cite the standard that we're measuring against, the performance of that unit benchmarked against the national performance, and then historical performance along the bottom. So this is whether an arterial blood gas was taken in the patient. The standard is it should be, so therefore the standard should be 100%, even if you allow for a bit of exception reporting, near enough to 100%. And in this unit it's 65%, and nationally it's 87%, and in 2003 it was 85%, so it's gone from 85 to 87 nationally over a 5-year period. So these are the kind of reports and data that we've been sending back to clinicians to try to effect change, but also reporting them at a national level. And what have we achieved? Well, there's lots more documents that have come out since then. So NICE have management guidelines for COPD, which didn't come out because of the audit, but which the audit has highlighted areas which have needed revision. We have NICE COPD quality standards, which quote the audit throughout, which I think is quite helpful. The DH has produced an outcomes strategy for COPD and asthma, which again quotes the audit in many places, and we have an NHS COPD commissioning toolkit for commissioners of services at primary and secondary care level. And none of these things are direct results, but when the audit data was presented to the DH, two high-level clinicians, two high-level administrators, and to high-level politicians, these things were happening, and it influenced and made change happen. So at a national level, I think we can say there's been some impact of the audit program. But if we look at what's happened to hospital sites, and again, this is very secondary care orientated, I appreciate, but that's what we've done so far, we can see that resources have increased in a lot of places. So in 2003, there was a median of 2 respiratory specialists per hospital. In 2008, that went up to 3. In 2014, it's up to 4. More doctors, there are more nurses, there are more trainees, there are more physios. All of those things seem to have improved. And there's wider service provision. So again, if we go back to 2003, there were virtually no supported early discharge programs. By 2008, there were about 35% of organisations had one, and now it's much, much higher. It's over double that number, so it's going up. Access to palliative care has gone up dramatically. So service provision seems to be getting better. Resources have improved, But when we go and look at the processes of care, we see very little change. It's a flat line, unfortunately, rather symbolic, I'm afraid, of something to do with the standard of care. So there's a question, there's a worry about why these things haven't translated into better care. And if we look at assisted ventilation, which I mentioned to you before, we still see, unfortunately, a high proportion of patients who should get the treatment not getting it, not any longer because they don't offer the treatment, because now everybody does, but because the clinicians don't give the treatment appropriately. And we often see also that patients who get the treatment don't get it within the recommended RCT evidence-based timelines. So there are still structural problems which seem to inhibit better patient care, which needs to change. Some other things, though, have improved, and of course everyone's delighted that length of stay has reduced. So is that a good thing, though? Because what has also happened is that readmission rates have gone up, and in the European audit, the UK had the highest readmission rates of anywhere, and one of the shortest length of stay. Not that I'm suggesting there's any relationship between those two things, but mortality remains high. It's lower this year in hospital, but we haven't got the out-of-hospital data. And so by reducing the length of stay, we might be just pushing the problem somewhere else, that people don't die in hospital, but they go home to die. So we have to understand the data in its richest sense. So what have we done differently this year? So firstly, I think we have, as I've said, acknowledged that quality improvement is really important. We have to do something more than just feeding data back this time. We have a QI group, and Dominique's a member of that. We have looked actively for links with external organisations because we don't believe that within our own remit and our own budget, we have the resource to have a national QI programme for COPD. But there are others who are developing that kind of a program at local level, at regional level, and higher level. And what we're trying to do is to link into them, to feed them with the data, with the information that will help inform those programs, in the same way as we saw national toolkits and national guidelines using audit data in that way. We think it's really, really important to emphasize the QI opportunities to all of those that participate, all of our clinicians. This is something more than feeding data back. And trying to help them, because there's a capability issue as well of how on earth do we manage to move from just collecting data and reading it and filing it on a shelf to doing something different. And I think the key thing is about engaging people and making it as easy as possible to do the right thing. And that, of course, can be challenging. This is a discharge bundle. It's something which is evidence-based now. It is something which has been trialled in West London and rolled out now across large parts of the United Kingdom. It's about having, a number of things, small number of things, that if they're done together, improve the process of leaving hospital to getting continuing care in the community and in primary care, and reduces readmissions and improves the patient experience, and interestingly also improves the clinical experience for nurses and doctors looking after patients. So providing something like this, a template, a tool which you can use, which is evidence-based, is one way we think we can move the QI agenda along. So engaging with professionals is important, though, because they are the leaders in whether it's primary care, secondary care, or community care. And what we're trying to do is to have a radical message that will get people's attention. So we put data be back, which is, there's variability, we're not doing it as well as we should do. We're now trying to have a radical message, which is that patients admitted to hospital with COPD care need to be looked after by a respiratory specialist in a respiratory ward. And that has massive implications, 7-day working, bank holidays, all kinds of things. So it's a radical message to try and grab attention. We need to balance it with the good things. So the data recording and the reporting, whether it's in the press or in the report itself, has to say all the great things that are going on, as well as the fact that we need to improve and do things better. We need to catch patients and professionals together, to bring them together so that there's a joint approach to this, that we're not fighting each other. And we have a strap line, something we can get behind. So who cares matters. You need to be cared for by the right person. And we need to get our national bodies, and we are engaging with organisations like the BTS and the RCP to get behind us on this so that we have their support. Commissioners, key in primary care, key in commissioning secondary care and intermediate care services. We're engaging with them. So basically we say What is it you want out of the report? How do you want them presenting? What's the information that's really important to you? And that's what we'll give to you. But at the same time, we think there's a little bit of education required, because what we don't want is a performance management, the lowest cost possible outcome for our patients. We want to encourage CCGs to commissioning things along the guides that have been published at national level. So that reporting will include what you want to know, but also what you need to know. So a combination of things that we'll try and educate commissioning in line with the national commissioning document. At a national level, there are various different organisations that we need to engage with, and we have been engaging. We've been in the all-party parliamentary group. Their report included, first recommendation, must have national audit of COPD. Win, okay, that's good. The domains are troublesome because they don't map to diseases. So we have to go and talk to everybody differently. Say, well, the only bit I'm interested in is this little bit of your audit, and I'm only interested in that little bit of your audit. That's a problem. Now, the problem may be ours, it may be theirs. It may be that we need to start to realign how we do audit or quality improvement programs. That what we have to do is to think about population groups now and not about single disease entities. Maybe that's the way we need to go. Maybe we need to have some combination which can capture this. The problem is, after the next election, we've no idea whether the domains will still be there. That's part of the difficulty in the planning. But engaging with people, really, really important. Engaging with organisations, really important. But most importantly, we think, engaging with the patients. So with the British Lung Foundation, which is the main representative group of COPD patients, we've been working with them. How can we provide information that will help patients? So we have the plain English version, conferences and newsletters. But yesterday we were in a meeting talking about how we might start to change the way that that charity supports change. So at the moment, most charities support information for patients and they support research. So we said, what about supporting quality improvement? Stunned silence, you know. What do you mean by that? Well, what about putting some training in place? What about sponsoring not a Macmillan nurse, so to speak, but a quality improvement person, nurse, from the BLF that would actually lead QI in an organisation or across a pathway? So radical new ideas we need to work with. We've been talking to them about having patient organisations, their patient groups, linked with each hospital to work together on a quality improvement programme. So patients working with their clinicians together, paired together. So we're looking at new ways of trying to engage patients. And lastly, what we'd like to do is to engage each individual patient by providing them with the information to argue for better care themselves. And this, and again, I apologise, you can't see it from the back of the room. This is a quality scorecard for a COPD patient, which we've trialled in outer North East London. So it has 6 key things that we think every patient in primary care should have done. So, for example, they've had stop smoking advice, they've had a diagnostic test done to make sure they've got the right diagnosis, they've had their inhalers technique, they've been considered for a pulmonary rehab program, they've been given support with self-managing their condition. And on this document, it tells you what the thing is, why it's important, a little bit in diagrammatic form as well as in text, and then a traffic light system tells the patient whether they've had that thing done or not. And we believe that if we can empower individual patients to change their own quality of care, that will start a revolution. What patients want to know is that their hospital is good, but they don't have choice about where they go often. They want to know their GP practices is good, but more than that, they want to know, is my individual care good? Because I might go to a great practice for diabetes and find it's not so good for COPD, but I've got diabetes and COPD. So it's about empowering patients to argue for their own care that we think will create a revolutionary change in QI. At the moment, we haven't got funding for this. So is anybody out there interested in stumping up a fiver, then we'll look at that. So, to summarise, reporting of data has limited impact. We know that, okay? I don't need to persuade any of that. The QI element is absolutely critical. We have to have that right at the beginning with a strategy as how we're going to roll that out across the programme so that everybody involved understands that that's part of what we're doing and not an add-on right at the end. Engagement, absolutely critical. Finding the key people is sometimes difficult in the current domain structure that we have at the top end. We have no resource or contract currently to develop or deliver a QI programme. So basically, I think that's over to the Healthcare Quality Improvement Partnership. Thank you for listening. questions now?
Yes, Mike has to shoot off straight after this, so if we could take some questions now, that would be great. Anybody in particular in relation to, I was really interested around the scorecard and the care bundles in particular, and I guess, you know, other people's thoughts around that, and anything similar you might be developing, using, supporting through your audits.
Great presentation, Mike. Really enjoyed that, actually, really. I'm going to see someone on Wednesday in respect to one of your questions, and I'll put that across to the Minister. The bit that we've had presentations on already hasn't actually mentioned carers.
Yes.
And I just wondered, really, in terms of how we engage in that much wider way, whether or not that's... Because, you know, I've heard patients, and absolutely right, and that's that clinical focus, really. But I think if we're looking at that whole rounded approach... whether or not, you know, maybe some of the national charities around carers could look to support this in terms of that training and that different way of thinking.
Yeah, you're absolutely right, and it's difficult in where there's a confidentiality issue to collect information from carers about named patients. I think there's probably a different approach needed for that. Certainly in terms of any integrated care network that needs to be set up, we've got to recognise that carers do an awful lot of unpaid support, and that we have to develop a network that supports carers to support the patient as well. So I absolutely accept that. I think it's difficult within the audit to collect that kind of information and data outside of asking a patient, for example, who is caring for them. And some of that we are collecting through primary care data collection will be to understand whether somebody's living on their own with or without support. As long as that's been collected and documented within the primary care record, we'll have that information.
Sorry, shall I just shout? Because the other part of that really is some of the patients are carers as well.
Sure.
And I think that's a really important one to read in, really, is that as well as caring for someone, they're actually patients as well.
Yeah, no, that's a very good point.
Sally Hull again. I loved your patient empowerment tool for primary care. I think that's a really powerful thing. And there's no reason that couldn't be linked to the documentation for the annual review that's already within something like QOF. And GP computer systems can actually pull those kind of tools out to make it easy to deliver it to patients. But the other thing I just wanted to mention is the use of computer prompts as a way of quality improvement. And I think that it's probably from secondary care perspective, it's a slightly underrated technique, which can really make a difference in primary care settings, so that you can, when a patient with COPD comes in, you can have a little thing that pops up and says, hey, they haven't had spirometry, you haven't done the annual review, or whatever it is, or they're on some crazy combination of medications. And I wonder whether you're going to be incorporating that kind of thing within your
so
your
that
audit.
obviously is really critical, how we then move and motivate beyond presenting data to making quality improvement. It's not part of our programme. We're not funded to do that kind of thing, but I think it's really important. We did do a programme in outer North East London, which I think you're aware of, where because, firstly, data recording in primary care was not of high quality. That's the first thing, because a lot of it's read-coded, and it depends upon lots of reasons and lots of past history as to how something is coded. We introduced a template which had two purposes. One was to try to standardize the coding that was used so we could have more comparative data, more reliable data. But secondly, also, for the annual review, we provided a template for nurses doing annual reviews to prompt them to do the right things, which are absolutely right. We thought was a good idea. Now, we have also done a research project in secondary care around assisted ventilation, where we gave a prospective audit pro forma for trainees, so that when they had a patient who should be considered for assisted ventilation, it required them to record a number of things, such as when did they do a blood gas, when did they consider, when was the decision made, what was the escalation plan, and we found it made no difference at all to the performance. So that's just a slight concern, that what we have to do is get away from people saying, yeah, I know that, but I haven't got time to do it, and moving on to the next stage. But I think the principle is a very good one.
Thank you very much. Just a couple of points. You raised the important issue of getting the third sector involved, and in fact, in the diabetes audit, we've got Diabetes UK as a partner in the delivery of the audit, which brings in the patient voice as well, so we've got them represented throughout the audit. But you also made a plea at the end for how are we going to get funding to promote quality improvement, and of course that is a problem for us all. In the old days of NHS diabetes, we had a partner that could help us spread that quality improvement training message, and we ran a series of master classes around the country, and one of the things that came out of that was a real recognition of how much training is necessary to get people just to get to grips with the key messages. And now what we're doing is investigating, replicating that sort of mechanism in collaboration with stroke, heart disease and kidney disease, and setting up a similar program under the National Cardiovascular Intelligence Network, putting all our resources together and with PHE's blessing doing that sort of thing again. And I really do think we all have to find ways of investing in that training and awareness raising all around the country.
Yeah, thank you. And just to be clear, the British Lung Foundation are a partner in the audit from the outset, but thank you, yes.
When you're collecting data, did you group them into different ethnic groups or not?
Yes, that is part of the data collection we do. Interestingly, the only data we have at the moment we can look at is that for hospital admissions, and there's two big things that have changed over time. Again, if we go back to 2003, something like 45% of the admissions were women and 55% were men, and 99% were classified as white, Caucasian, British. If we look at the data from 2014, we now have a majority of women who are admissions rather than men, and we have something like, I think, 4% who are classified demographically as not white, British, Caucasian. So there's been a small shift, but a big shift in the gender change.
Nice one. I've got
Hello,
that.
Yvonne.
Hello. I just want to draw out a little bit with you, Mike. Having put this QI structure in place from the outset in this programme, what things do you think have happened and decisions made specifically around the design of the audit programme that might not have happened at that stage had you not put that structure in place from the outset?
Yeah, I think probably, well, it's two things. Firstly is I think everyone understands why we're collecting the data and what the use is. So the thought is always, we're collecting this, what's the purpose of collecting this data item? Because how are we going to use that to try and make change happen in the future? And the second element, I think, was when we looked at the data items, we blueprinted them against the standards we thought were important to measure them against. Again, with a view to understanding where the areas of deficiency were that we could then make an intervention to improve against. So that was really key part of planning the data sets in all the elements of the audit we've had. One more for the road. That's all I've got. 30 seconds.
There's really a comment about the importance of QI in the paediatric diabetes audit, which has been running for 10 years. There have been absolutely no changes in outcome for about 7 years. And then NHS Diabetes came along and they persuaded the powers that be to invest in managed clinical networks for paediatric diabetes in England and best practice tariff and a quality assurance peer review programme, and we're beginning to see change. So it does take time, though, but having no quality improvement programme or strategy before led to nothing.
Yeah. And just to comment on that, I think that's really good news to hear. And I think maybe we need to learn from that about what we can do at a national level to put in structures that support change and rather than have a tariff structure which doesn't encourage quality improvement, or a contracting structure, I think we can learn a lot from that, yeah.